is if you look at the bucket handle, that's what usually you have to attach to the periphery, the main meniscus. You see how twisted and yucky looking it is. That's from chronic um, trauma to the bucket handle, and there's no way to repair it. Most bucket handle tears are not repairable. Maybe probably between 40 and 50% are repairable. But like I said, probably 40 to 60 are not. Yeah. I know that's a kind of a contradiction, but that's the way it is.
Yeah, so this is in a cadaver. This was really a chronic lesion that had been
there for that's like an open meniscectomy.
Yeah. And so, as you're all actually aware, this is a coronal image, and here this is a T2 weighted image, and here we can see the peripheral rim, and this is the bucket handle fragment. This is different from the last one in the fact that the meniscal fragment here is very black. Look, and this was an acute injury in a younger individual, and there you can see the bucket handle fragment, and then the peripheral meniscus. And as you all also know, another sign that you can see in the sagittal plane is the double ACL sign, which you can see. This is the bucket handle fragment. That's the anterior cruciate ligament with the bucket handle fragment underneath it. So one of the reasons why, well, there are a lot of reasons, but when you do young athletes, when you do MRIs of the knee, we're certainly looking for these kind of tears because, as we'll talk about later, the data now shows that the patients do far better if these are repaired than if you remove them. And if you wait too long after the injury, where, as John said, you get plastic deformation and degenerative disease in this central fragment, then it's not repairable and their prognosis is much worse. Okay, who's next? Okay.
All right. So 17-year-old male with knee pain after trauma, increased pain and locking 1 week after first MR scan. All right. So the first, both sagittal images. This seems, we're at the medial meniscus. Posterior horn seems to have some increased signal, but I don't really see an anterior horn either. But this might be along that. But there's a lot of signal angle, yeah. But there's a lot of signal in the posterior horn, and it's going to the surface. All right. So looking at this, looks like this looks like a peripheral tear right there, yeah.
It's a little bit complex because you have both vertical
and
horizontal components. So this was on 7.
If you look at this, don't you think there are more than one directions of the lucency in the meniscus?
Yes, it is. And that's why I would call this a complex peripheral tear.
Yeah, I certainly go along with that.
Good. So this is on 7.
Which is unusual for a 17-year-old.
Yes, I agree. So this is on 7/12/11. The patient went back into athletic activity, and came back with increasing pain, and this is on 7/26/11. So a couple of weeks later.
Oh. Well, I think you see blunting now of that posterior horn right there, and then on the next sagittal image, it looks like there's a flipped portion of the meniscus now into the WPCL sign. Yeah, so it's a bucket handle.
Look at the anterior part. Is there an attachment of the meniscus anteriorly?
Yeah, I think you're saying that you don't see it here.
No, it's gone. So it flipped backwards towards the center. Then the entire meniscus probably it's kind of more than a bucket handle.
Well, you can see here is the bucket handle fragment in the notch of the knee. It comes up here, and then we'd have to have the next cut over to see it come all the way to the anterior horn.
Yeah, I'd love to see it.
Yeah, and then what do you see on the coronal image?
So on the coronal image, it looks like the it looks like there's some buccal handle right there, yeah, and the intercondylar notch, and that's blunted. Yeah, yeah.
That's a tiny little piece left there. Almost the entire meniscus is flipped into the notch.
Right. So this was and if you go back to the original, you can see the tear plane is here. So all of this flipped into the notch, and we're just left with that small peripheral rim.
Yeah. Yeah, on the sagittal view, you don't see anything anteriorly in terms of attachment.
Yeah, right. Part of that is just the angle of the cut, but I agree with you. It affected.
Yeah.
And so this is a peripheral tear that then progressed onto a bucket handle tear. So the kind of the progression. Common though, is it? Well, all bucket handle tears probably occur this way.
Bad coach.
Well, we don't always see it at this stage. We usually don't see it until it displaces because then they get more.
No, what I'm saying is a coach allowing a kid to play with prior MRI should be punished.
Yeah. Well, we can talk a lot about coaches if you want, but maybe we should.
Another time.
Yeah. Okay, and then here we can see, here's a case where you can see a very abnormal posterior horn, and here we basically have what looks like two menisci anteriorly, and this is another displaced meniscal fragment that's now up against the anterior horn, and this patient had a locked knee. Another type of displaced tear, here we have a peripheral tear, really the posterior horn, and the entire posterior horn, instead of displacing into the notch of the knee, displaced anteriorly. And the patient then has locking because as you try to extend the knee, you got too much mass here in the anterior part of the compartment. It starts compressing here, and they can't go into full extension. And one of the worst prognostic factors in knees is if you cannot have full extension. That's why people will, well, we'll talk about ACL grafts later, but you tend not to want to operate on do the graft until they get full extension first after a tear. And after surgery of any kind, you've got to maintain that you have full extension. Otherwise, the prognosis is very poor. So, so this is a locked knee, and that's due to really a displacement of the bucket handle tear. See, who's next? Michael? Oh, you think this?
So sagittal MRI at the intracondylar notch. So again, I'm kind of just seeing a double PCL sign here.
It's almost a triple.
Oh yeah. So again, you're just looking for a displaced tear.
Go through the sagittal plane.
So,
what are you seeing here?
Well, it looks like there's blunting of the posterior and the anterior horn.
So we've got a lot of loss of the volume of the posterior and anterior horns. Then we go forward here, and then we're starting to get this big kind of mouth thing anteriorly. And then what do you see here?
Again, similar, you see this kind of displaced flipped bucket handle fragment into the line into the notch.
Now, notice this one, that you have a lot of increased signal intensity within that flip fragment, which generally means that it's chronic and old. And this kind is typically not a good candidate for repair because that central flip fragment really is too degenerated. Here are the coronal images. Again, we see that the fragment in the notch of the knee, a lot of increased signal intensity. So the quality of the tissue here is probably not going to be such that you can have an adequate repair. So this is one, like John says, which are very common if you wait too long, where it's really not a candidate for a repair that you have to do a resection. So one thing you need to do is comment on the quality of the tissue of the displaced fragment when you see this on MR. This particular patient also had a torn ACL. Did I show that here?
That's really similar to the one we read out today.
Yeah. See, here's an ACL tear here. Yeah.
Exactly like this.
And if you do a meniscal repair, you also have to do an ACL repair. We'll talk about what happens when you have instability from an ACL insufficiency later when you get the ACL. But if the ACL is non-functional, then a lot of the stability of the knee then goes to the menisci. You put a lot of strain on the menisci, and you have a much higher risk of meniscal tears developing in people who are ACL deficient. And if you try to do a repair, the repair will not, it has a very poor survival if the ACL is insufficient. So you have to do both of these.
What Fox and I used to do, we did quite a few of these. We used to take the torn bucket handle portion, leave it attached anteriorly, and use it as a ACL by attaching it to the ACL and then drilling a hole into the femur and suturing the meniscus and the torn ACL into that hole. So we tried to repair the ACL pretty much at all costs, and every ACL was repaired by us. We did not choose whether it's attached here, there, or anyplace else. Everyone we tried to repair.
Okay. Great.
But we were kind of unusual people. Most orthopods didn't do that.
Okay. Yeah, we'll talk more about ACLs when we get to those. That's good. Okay, Jennifer?
So I see some blunting here of the lateral meniscus, and it looks like there's a displaced low signal intensity fragment along the intercondylar notch. No, on the other side, sir. Yes. Medial meniscus. So this looks like another bucket handle tear.
So this was 10 Here you can see the bucket handle fragment. And there's the peripheral rim, which is small. And on the axial rim, you can see that displaced bucket handle fragment. And then now the patient, this is on 1016 only.
Get closer to the mic, John.
So this is the follow-up MRI, and here it looks like there's worsening increased signal intensity and irregularity along that bucket handle fragment. Yes.
What do you think happened to this meniscus on this image, at least?
So I think perhaps that fragment has detached from the meniscus.
Yeah, it looks like it was removed, doesn't it? This central portion, the bucket handle.
So a couple of things. We have a bucket handle fragment here. We don't see the attachment of the anterior cruciate ligament. And
ACL is bye-bye.
So there's the bucket handle tear, and there's that. Now, let me tell you this. Between 10:8 and 10:16, the patient had surgery. What did they do?
Yeah, and they removed the bucket handle and
This is Jennifer's case, not yours.
So it looks like they removed that bucket handle fragment.
When you say that, Go back and look at the periphery. What
Let's
does
see.
the periphery look like here?
It's blunted.
Okay, now what does it look like here?
Oh, I guess they attempted to repair that
They did repair.
fragment, and the ACL is also now attached
Well, they did a graft
to the graft.
Is this one of old Fox's?
No, I don't think Jim did this one, but this is a repair of the bucket handle. So this is a repaired bucket handle tear. And then, as I was saying, with an ACL tear, then you have to then stabilize the ACL, and they put in an ACL graft. So this is a bucket handle repair with repair of the ACL.
Well, the meniscus doesn't look like it was repaired, John.
It was.
It's not big enough to.
Yeah, but look, see how it looks here, John. See how truncated.
Yeah. Yeah. But
And then here, this was a repair.
okay.
And it has a sharper point. It's still a little bit blunted, but it.
Where's the central portion, or are we too far anterior?
No, we're right in the center. That central bucket is sitting right here, and the peripheral rim was right there, and this has been sutured back together.
Okay.
So this is a post-op appearance of a repaired bucket handle tear. Okay. And then here's just kind of a bucket handle tear. Anyway, so let's go in here. What do you think of this one?
Sure. So in the sagittal image, we see the medial meniscus looks like there's abnormal signal. It looks mostly vertical in the posterior aspect of the medial meniscus here.
This is kind of junction.
Push your horned body, yeah.
So we have a vertical tear here. It's in the peripheral zone. So we're really in the red zone. So
and it's a young athlete, so.
And then here are the axial images.
Yep.
And there you can see the peripheral tear right here. So we'll talk more about ramp lesions later. Let me make sure. Yeah. Forget. So this is a peripheral tear. This is there are several types of ramp lesions. A ramp lesion, by definition, is a tear of the posterior periphery of the medial meniscus after someone has an anterior cruciate ligament tear. And they can be divided into about 4 or 5 different types, which have different significance. But maybe, I guess this patient had an ACL tear. But anyway, so these are peripheral tears. Many people now believe that you should go in and surgically stabilize these so they have a higher chance of healing. In the previous days, people would try to leave these alone, and as it said in that one paper that we had, about 95% will heal. The more centrally you go, the lower the likelihood of healing. We'll talk more. Okay, ramp tears. Okay, so we'll talk about ramp tears now. So ramp tears are longitudinal peripheral tears of the medial meniscus involving the posterior horn near the meniscocapsular ligament, or the meniscotibial ligament, or the red zone of the posterior horn. Most people won't use this term unless it's in association with an anterior cruciate ligament tear. And then what happens is, as you know, is that you get displacement. You get a rotatory displacement typically with the ACL tear. You get the where the femoral condyle moves posteriorly, and you get a shear injury as the femoral condyle impacts the posterior edges of the tibial plateaus. But the ramp tear is really only on the medial side.
So this is O'Donoghue's triad.
If you if you also have a medial collateral ligament tear.
If I was to bet, I'm sure that this had a medial uh, tear.
In my experience, very few of these end up having medial collateral ligament tears, but some of them do, and they would be O'Donoghue triads, right? So they have a classification of these 1 through 5 with 3A, with 3B and 4B. So we'll go through these. So again, you can have a meniscocapsular ligament tear, a partial superior tear, partial inferior tear, meniscotibial ligament tear, complete posterior horn tear, complete meniscojunction tear, and peripheral horn double tears. So let me just go through what these look like. I think the bottom line in clinical practice is whenever you see an ACL tear, you have to look carefully at the posterior horn of the medial meniscus to see whether there's an injury there. And then the situation is threes through 5, it's good evidence that these patients do much better if you do a repair of the meniscus. 1 and 2 are relatively stable, and they will do fine without surgical repair. I'm not sure we can always, by MR, differentiate the 1 and 2 from 3, 4, and 5, but you can try. The main thing is that you point out there's a lesion there to make sure then the arthroscopist knows to look there at the time of arthroscopy for the ACL. So,
John, can you go back?
sure.
Like you see on many these types that doctors like to use 1, 2, 3, A, B, C, D, and whatever. If you look at the name on top, it says grief, and on bottom it says grief. And that tells you all you need to know about this system of that's being used, in my opinion. Just my opinion, that's all. My grief.
I'll fix it, John.
I'm trying to be funny.
How's that? Okay. Now,
now you take all the fun out of it.
but I think what John's getting at is the vast majority of people out there, if you say the patient has a 4B grief lesion, 99% of people will not know what you're talking about. So as we've said before, for most of these classifications, they're done for research primarily. The main thing is that you need to describe the findings so that whatever classification system the surgeon likes to use, they can classify it by the findings that you provide. So I think that's important. So what does the anatomy look like back here? Well, here's the tibial plateau. Here's the articular cartilage coming back. Here's obviously the meniscus. And then we've got the meniscocapsular ligaments, the meniscocapsular ligament here. There's the capsule back here. The the meniscotibial ligaments back here, and that's the posterior capsule. So here basically the bottom line is that the superior ligaments here are the ones that go to the capsule, and the inferior ligament here goes down to the meniscotibial area. Now, most of the time, I can't see these individual structures. The bottom line is if you just have a tear in the top here, that's typically a stable lesion. But if you have a tear that involves the mid and inferior portions of the peripheral attachments, then that's going to be an unstable tear. And that's probably because the most stable connection is really the meniscotibial connection here, because it's a very short connection. These others just go out to the capsule where they're much more lax and loose and less stabilizing for the meniscus. So as we go through the classification system, the low-grade tears are going to be superior tears. All the high grades are going to also involve the inferior attachments. and they're claiming that you can see little black lines here of the different attachments. The capsule back here, the meniscotibial, and the meniscocapsular up there. But it's not always, they're not always well visualized even at 3T.
That's mainly shredding of the capsule at the attachment.
Okay.
I think what happens to the capsule is it kind of pulls apart, and of course the meniscus tries to tear away from the capsule due to the injury, and so it's shredding instead of just single tear.
Okay.
It's probably because of rotation.
Okay. So here is a type 1 tear, which is just a tear of the meniscocapsular attachments superiorly here. This would be type 1. Here's one that was surgically proven, type 1, where you can see the signal just involving the superior attachments here to the periphery of the meniscus. And this is the tibia and the tear right in through there.
Well, he's looking at this from the medial side, not from anterior. I don't think.
Okay.
So I don't know whether he fixed this or not. I don't know where you would attach this.
Yeah. Well, in this paper, they say these are ones that don't need to be repaired. A type 2 tear involves the superior posterior margin of the meniscus and the meniscocapsular attachments, which they're saying it's going in, right in through here. This is also thought to be a stable lesion.
I would have treated this with a cylinder cast, but whose knee was arthroscoped in there?
These are patients.
This patient?
No, this is a different patient than the last one.
Oh, different patient. Okay, that's what I figured.
Patients, right.
Yeah, this is a kid. This is an ideal case for casting.
Okay.
And it should heal.
Yeah, so this they said is a lesion that is a stable lesion. Now here is the type 3. There's a type 3A, which involves the inferior portion of the meniscus, and then involves the capsular and the meniscotibial attachment in this location. See, it's an inferior tear down here. And these are thought to be unstable lesions that need to be surgically stabilized if they're inferior here. So that would be a type 3A ramp lesion. Here's a type 3B ramp lesion where you can see that the impaction injury you can see on the bone in this location. But what happens is this is a tear that doesn't involve the meniscocapsular, but does involve the meniscotibial. But again, it's that inferior meniscal lesion. In this case, you primarily see that the inferior meniscotibial ligament is no longer present. And you can see the bone injury in this location. And the bone injury is somewhat helpful. The type 4 lesion is one that just involves the periphery of the meniscus. And the peripheral component, the meniscotibial and the meniscocapsular ligaments are still intact, but you have this longitudinal tear through the periphery of the meniscus. And this would be a 4A, and this is one that, according to this paper, should be surgically stabilized. And this is
It depends on how long the tear is. Campbell's would have a fit about stabilizing this one. This is you might immobilize this case and they heal within 6 weeks.
okay. The next one is where the meniscus isn't torn, but all of the meniscotibial attachments are torn, which we can see right through here. And this is 4B. This is also considered an unstable lesion that needs to be surgically stabilized. In the past, I don't think anybody would have thought of operating on this lesion, but now at least in this particular paper, and this is a radiology paper, but it references a number of orthopedic papers that consider this an unstable lesion that should be repaired. And then finally, there's a type 5 lesion where you basically have a double tear of the periphery of the meniscus, which is unstable and is thought to require surgical stabilization. Now, all of these are peripheral tears, and there's a lot of literature that states in the past that these peripheral lesions can heal very nicely on their own. But some of the more recent orthopedic papers say the prognosis is better if you surgically stabilize these.
If they're so recent, how did they come up with a prognosis this soon? Well, of course, I haven't read the paper, and I don't know how old lesions these are.
Yeah, well, the papers have been published in the last 2 years, and a lot of them had 5-year follow-up on patients. So the actual initial surgeries were done 7 or 8 years ago.
5 years is not that much, but anyway.
It could also be maybe there's.
I haven't read the paper, so I'll shut up.
Okay, maybe they're trying to justify surgery, John. So anyway, those are ramp tears, and they're a very hot topic right now in the orthopedic world, especially in sports medicine. Okay, let's see, who's next?
Okay, so coronal image through the knee. I think what I'm looking at is in the medial meniscus, there's kind of an obliquely oriented increased signal line. Yeah, right there. That looks like a peripheral tear extending to the surface.
This is a peripheral tear. It's really in the body. It's not really posterior horn. The ACL is intact in this patient. So this would not be a ramp patient, but it would be a peripheral tear. Certainly in the past, most people would, some people, what you don't want to do in this case is remove the meniscus, because this would be really almost a total meniscectomy. And we know the prognosis is poor there. We also know that up to 95% of these will heal spontaneously. So this is one that most people, I think, would treat the way John's talking about, where you try to decrease motion in the joint for a while to allow this to heal. Agree, John?
Yes. Yes. Try to use the mic a little closer, John.
Okay, I will. Let me see. Yep.
So this is showing a sagittal image that is showing a complex tear of the posterior horn of the lateral meniscus.
So that's what it was at this time. The patient came about 8 months later, and this is what it looked like.
So now there's blunting of that posterior horn. It looks like it says they have partial meniscectomy.
So this is a partial meniscectomy of a peripheral lesion like this, a complex lesion like this. There were people who would do primary repairs of menisci back in 2003, but it wasn't considered the standard at that time. So what does the literature show? What is the long-term outcome after arthroscopic repair versus arthroscopic partial meniscectomy for acute traumatic meniscal tears? What are your thoughts, Ashu?
I'm guessing that repair has been shown to be better.
Okay, so this was a level 3 study, 81 patients, 42 repaired, 39 had meniscectomy, and they had middle and long-term follow-up. For those who had no arthritic changes on x-ray, that was 80% of those who were repaired, but only 40% with meniscectomy. So there was much more progression of degenerative disease in those that had partial meniscectomy versus the repairs. The return to pre-injury activity levels, a lot of these were athletes, was almost 100% with the primary repair, but only 50% in partial meniscectomy. But as what they found is that these numbers significantly decreased if you had ligamentous laxity, and therefore you have to repair the instability. But you had a 90% repair rate if you had ACL reconstruction. So this paper showed that patients do much better with repair than if you do partial meniscectomy, but you have to do the ACL reconstruction along with everything, because if it's an unstable knee, you will not have success. Arthroscopic meniscal repair offers significant improved results for isolated traumatic meniscal tears. That was their conclusion. So indications for meniscal repair, typically young athletes, peripheral tears in the red zone, if you have sharp black margins and normal signal intensity within the menisci, those are the ideal candidates for primary repair. And then so, last year, and then for stable tears, they can heal on their own. With acute tears, you can have repair. Okay. Another concept that's closely affiliated with the ramp lesion is the concept of the break-stop function. And this means that if you have a peripheral tear back here of the posterior horn of the medial meniscus, if you have an inferior tear, which we said were the unstable ones, then what will happen if you have, if the femoral condyle starts pressing backward on the meniscus, is you'll get meniscal displacement above the semimembranosus insertion, and that produces instability of the knee. The meniscus will no longer function properly to stabilize the medial aspect of the knee. Okay, so this kind of goes along with the ramp lesion, and that concept is called the break-stop function. And then you can see this on MR occasionally, though you have to remember MR is not upright with weight on it. This is the normal position of the periphery of the posterior horn of the medial meniscus. Here is a posterior horn which is extruded a little bit, but the fact that it's no longer positioned anterior to the vertical line that goes to the posterior edge of the medial tibial plateau, if the periphery of the meniscus is peripheral to that, then you've got an unstable peripheral tear here. In the setting of an ACL, this would be an unstable ramp lesion. This is poor prognosis. So that's kind of how you evaluate that posterior horn of the medial meniscus. They call this the uncovered medial meniscal sign as an indication that you have basically an unstable ramp lesion. But what you'd really like to do is repair this right after the injury when you repair the ACL, so that you don't go into it. This is more of a chronic instability pattern in this patient. And you can see some degenerative diseases developed of the meniscus.
It's much too late to repair.
Yeah, right. Okay, so looking at some of the anatomy, this is the posterior meniscotibial attachment of the medial meniscus, which we can see there in that location. The lateral posterior horn, the lateral is more of a C-shaped. The medial is not so much of a C-shaped. So actually the posterior meniscotibial attachment of the lateral meniscus is often more anteriorly positioned than the medial side. This is kind of an oblique coronal image. So you have to follow the lateral side over a couple of cuts to go from its attachment on the bone till you get into the meniscus, whereas on the medial side, the meniscus and the attachment really is in the same coronal plane. So you have to look at them a little bit differently. Anteriorly, this is the meniscotibial attachment of the anterior horn of the lateral meniscus. And because it's C-shaped again, that's going to be posteriorly positioned with respect to the anterior attachment of the medial meniscus. So we have to go another couple of cuts before we see the medial attachment right through here. And this is a transverse ligament across there. I'm surprised I didn't talk about the importance. Well, we'll talk about the transverse ligament. I'm surprised I didn't do it. Okay, anyway, that's the transverse ligament. let's see. Why don't we stop and let's talk about root tears tomorrow. The root tears are important. When I was in Santa Barbara with Rick Ryu, we did a study of a number of knees where we saw root tears, and we wrote up a paper. This was in the around 1990, and submitted it to a radiology journal. They had an orthopedic surgeon review it, and it was rejected because the orthopedic surgeon said root tears don't exist. And there was a time when you could not, in tight knees, it was very difficult to see these posterior root attachments, and therefore people didn't realize that they really existed, or at least the majority of orthopedic.
And that was probably before arthroscopy.
Yeah. Well, 1990 arthroscopy had only been around for a couple of years.
I know, but golly, I knew about posterior root tears in the 70s when we did open procedures. But I didn't publish anything, so
yeah.
A lot of orthopods, in fact, probably 99% of orthopods didn't publish anything.
Yeah. Well, so we'll talk about root tears. They turn out to be quite common and very important, and they're also an indication for repair. But we'll start that tomorrow. Okay. Any questions? Okay. Thanks, everyone.
Take care, everybody.